Good morning or afternoon. My name is Cynthia Wong. I am a Malignant Hyperthermia Hotline consultant, and I have the honor and privilege of narrating this education session on malignant hyperthermia. Today we will talk about the definition of malignant hyperthermia, including the epidemiology and cellular mechanism of MH. We will then go on to discuss a malignant hyperthermia crisis and its treatment in the operating room. We will talk about the genetics of malignant hyperthermia, including the testing for MH. And finally, we will end with common questions that are addressed to hotline consultants. Malignant hyperthermia is an inherited disorder of skeletal muscle. It is triggered in susceptible humans or animals by volatile anesthetic agents or the muscle relaxant succinylcholine. It is characterized by hypermetabolism, resulting in skeletal muscle damage, hyperthermia, and death if left untreated. The incidence of malignant hyperthermia varies between 1 in 10,000 to 1 in 50,000 anesthetics. The pediatric incidence appears higher in 1 in 15,000 anesthetics. The incidence may depend upon age, as discussed above, sex, concomitant drug administration, or patient comorbidities. For example, MH appears to occur more commonly in males. It occurs less commonly in patients who have previously been administered a sedative hypnotic agent before the administration of the triggering anesthetic agent. The onset of MH most commonly occurs in the operating room, but it may also occur within the first 20 or 30 minutes after admission to the post-anesthesia care unit. The onset of MH may be fulminant or more indolent. The full-blown syndrome may occur within minutes of the induction of general anesthesia, or the signs and symptoms may first appear after several hours of exposure to triggering anesthetic agents. Within the last couple of years, we have also become aware that MH may be triggered by environmental triggers independent of exposure to anesthetic agents. In the next couple of slides, I will discuss the pathophysiology and cellular mechanism of malignant hyperthermia. This slide schematically depicts a skeletal muscle cell. The contents of the skeletal muscle cell are primarily the myofibrils of the contractile apparatus. The whole cell is surrounded by a plasma membrane, and there are invaginations of the plasma membrane deep into the interior of the skeletal muscle cell that are called the transverse tubules or T-tubules. The transverse tubules and the myofibrils are surrounded by cavities called sarcoplasmic reticulum, which store intracellular calcium. I'm going to blow up the red box with another schematic drawing in the next slide. This slide is another schematic depiction of the interior of the skeletal muscle cell. The cell or plasma membrane is the solid line across the top. Number 2 is the invagination of this membrane into the interior of the cell, called the T-tubule. Number 3 is a protein that is embedded in the wall of the T-tubule, called the dihydropyridine receptor. And number 4 is a very large protein that is embedded in the wall of the sarcoplasmic reticulum. Number 5 is the sarcoplasmic reticulum, which is the cavity that stores calcium in the interior of the cell. And number 6 depicts the contractile proteins in the interior of the cell. In the lower left-hand corner, you can see a mitochondria. The mitochondria are responsible for producing energy for the cell, energy in the form of ATP, and this requires oxygen and glucose or fatty acids. Let me walk you through what happens during normal cell contraction. So back up at the top at number 1, when the nerve cell signals to the muscle cell that it should contract, sodium is pulled into the interior of the cell. This induces an electrical current along the cell membrane, which is transmitted down the T-tubule and through the dihydropyridine and ryanodine receptors into the sarcoplasmic reticulum. This signals the sarcoplasmic reticulum to release calcium through a channel in the ryanodine receptor into the interior of the cell. This increase in intracellular calcium then causes the contractile proteins of the cell to overlap and therefore contract. It also tells the mitochondria to start producing more energy for the cell. After the cell contracts, the calcium is taken back up into the sarcoplasmic reticulum. This is depicted by number 7, and the muscle cell relaxes. The problem in malignant hyperthermia is a dysregulation in intracellular calcium homeostasis. Calcium is released from the sarcoplasmic reticulum in quantities that are larger than normal. This causes an increase in intracellular calcium concentration, which causes the actin and myosin to continuously contract, resulting in a contracture. This produces heat because of the increased work of the muscle cell. Oxygen is consumed and carbon dioxide is produced in the process of the mitochondria trying to make more energy for the cell. And eventually the cell runs out of oxygen and metabolism becomes anaerobic and lactic acid is produced. Eventually the cell runs out of energy. The cell breaks down and releases its contents into the central circulation, which causes the downstream effects of malignant hyperthermia. That concludes our brief pathophysiology lesson. I've put some slides of pigs in the presentation not only to break up the sections of the talk and because they're cute and they're my daughter's favorite animal, but also to point out that malignant hyperthermia occurs in pigs, and in fact pigs have been an animal model for many of our discoveries about malignant hyperthermia in humans. In the next section of the talk we will talk about the malignant hyperthermia crisis and its treatment in the operating room. Commonly, tachycardia and hypertension are the initial signs of malignant hyperthermia in the operating room. However, these signs are often missed because tachycardia and hypertension are very common, and the other etiologies of tachycardia and hypertension are much more common than malignant hyperthermia. Tachypnea and an increase in minute ventilation are more specific for malignant hyperthermia, but these signs can also be missed if the patient is paralyzed. The most specific indicator of an impending malignant hyperthermia crisis is an increase in expired or end-tidal carbon dioxide. Anesthesia providers often use what is called a circle system to administer oxygen and anesthetic gases to anesthetize patients. This allows the patient to rebreathe their expired gas, cutting down on the amount of anesthetic agent and also decreasing environmental pollution and loss of heat to the environment. In order to do this, there has to be a carbon dioxide absorber in the system because we don't want the patient to rebreathe the carbon dioxide that they have expired. During a malignant hyperthermia crisis, the carbon dioxide that the patient expires increases markedly. This causes the carbon dioxide absorber to be used up, and the absorber becomes very heated and turns blue. Anesthesiologists continuously monitor expired or end-tidal carbon dioxide during a general anesthetic procedure. You can see in this graph that the expired carbon dioxide is normal, and then within a couple of minutes it acutely increases to abnormal levels. This acute increase in expired carbon dioxide concentration is a hallmark of malignant hyperthermia. However, there are other causes of an increase in expired carbon dioxide, including a malfunction in the one-way valves of the circle system or a problem with the carbon dioxide absorbent in the circle system. You'll recall from our discussion of the pathophysiology of malignant hyperthermia that the increase in intracellular calcium concentration causes the downstream effects of malignant hyperthermia, including skeletal muscle cell contracture resulting in rigidity, heat production, excess lactate production, oxygen consumption and carbon dioxide production, and eventually cell breakdown. The initial signs of malignant hyperthermia in the operating room include tachycardia and hypertension, tachypnea and an increase in minute ventilation, and an increase in expired or end-tidal carbon dioxide, as we just discussed. Other signs include skin mottling, rigidity, which may be isolated masseter muscle rigidity or total body rigidity, ventricular dysrhythmias, which are most commonly caused by lactic acidosis and hyperkalemia, hyperthermia, and myoglobinuria, which is caused by the breakdown of the muscle cell and release of myoglobin from the interior of the muscle cell. Finally, if the malignant hyperthermia is not treated appropriately, DIC or disseminated intravascular coagulation results in bleeding from multiple sites. There are several laboratory findings which are typical during a malignant hyperthermia crisis. In a venous or arterial blood gas, a mixed respiratory and metabolic acidosis is common. Hyperkalemia is a common finding. A common but perhaps late finding is hypercaemia and an increase in serum and urine myoglobin. And finally, abnormal coagulation tests may result if MH is left untreated. The successful treatment of a malignant hyperthermia crisis in the operating room requires the performance of multiple simultaneous tasks. Because the anesthesia provider cannot perform these tasks alone, he or she requires the help of all of the team members in the operating room. Initially, the anesthesia provider should call for help, turn off the triggering agents, alert the surgeon and nurses in the room of the impending malignant hyperthermia crisis, and hyperventilate the patient with 100% oxygen using high gas flows. If the patient is warm, cooling measures should be initiated. Most importantly, an assistant must begin to mix dantrolene. Dantrolene is the life-saving drug in a malignant hyperthermia crisis and must be administered in an adequate dose as soon as possible after the diagnosis of malignant hyperthermia. Dantrolene works by stopping the release of calcium from the sarcoplasmic reticulum. The initial dose is 2.5 milligrams per kilo. Dantrolene comes in a lyophilized powder, 20 milligrams per bottle, and has to be reconstituted with sterile water, 60 milliliters for each bottle. An average 70 kilogram adult would require 9 bottles of dantrolene for the initial dose, so that it requires at least 1, if not 2, providers to concentrate on mixing up and administering the dantrolene. Dantrolene should be administered quickly through a large bore peripheral IV or central line. The symptoms of MH usually resolve within several minutes after the administration of dantrolene. If they don't, a repeated dose of dantrolene has to be given until the symptoms resolve, and although symptoms usually resolve with 1 or 2 doses, it may take more doses to treat the malignant hyperthermia. This slide depicts the effect of the dose of dantrolene on malignant hyperthermia symptoms. Time is along the x-axis, and minute ventilation and end-tidal carbon dioxide are along the y-axes. You can see that after about 6 hours of anesthesia time, the minute ventilation, the blue line, and the expired carbon dioxide concentration, the yellow line, start to increase. Finally, at about 12 hours, this is recognized as malignant hyperthermia. Dantrolene is administered at the arrow, and you can see that within a very short period of time, both the minute ventilation and the expired carbon dioxide concentrations decrease to normal levels. While providers are mixing up and administering the dantrolene, other providers need to perform other tasks. These include establishing large bore intravenous access and perhaps an A line and a central venous line. Somebody needs to draw lab values, including an arterial or a venous blood gas, electrolytes, BUN, creatinine, CK, and myoglobin, and a DIC panel. If a Foley is not in place, it should be placed, and the administration of cool IV fluids is recommended. If the patient is hyperthermic, active cooling measures should be initiated. These include turning down the temperature in the room, uncovering the patient, and placing ice packs in the neck, groin, and axilla. Cool intravenous fluids can be administered, gastric lavage can occur, and if the abdomen or the thorax are open, the surgeon could elect to place sterile ice in the surgical field. It's important not to overcool the patient. Active cooling measures should cease when the patient's temperature is about 38 or 37.5 degrees Celsius, because the patient will continue to cool once active cooling measures are discontinued. Dysrhythmias, if present, are usually secondary to acidosis and hyperkalemia. Therefore, the acidosis should be treated with the administration of sodium bicarbonate, and standard measures for the treatment of hyperkalemia should be initiated, which include insulin, glucose, and calcium. Calcium channel blockers should be avoided as they may adversely interact with the dantrolene. The Malignant Hyperthermia Association of the United States has developed a protocol for the recognition and a treatment of malignant hyperthermia crises in the operating room. They recommend that this treatment protocol be posted in all operating room environments where triggering agents are administered, and that providers consult this protocol when they suspect that malignant hyperthermia is occurring. After the immediate malignant hyperthermia episode has been controlled, the patient should be sedated, core temperature should be monitored continuously, and urine output should be maintained with IV fluids and diuretics. If the surgery occurred in an ambulatory care facility, the patient should be transferred to a hospital. All patients should be monitored in an ICU environment for at least 24 hours after the MH episode. Central core temperature monitoring should be continuous, and serial labs should be drawn for the first 24 hours. Creatinine kinase usually peaks many hours after the acute event. Therefore, the providers should monitor serial creatinine kinase levels until they see the peak of the CK and the CK decreasing. Dantrolene should be administered in a maintenance dose for at least 24 and up to 48 hours after the initial event. MH can recrudesce in up to 25% of patients in the first 24 hours, and therefore dantrolene is recommended to protect against this recrudescence. Finally, myoglobin is toxic to the kidneys, and therefore extra saline and sodium bicarbonate may be necessary to protect the kidneys from myoglobin toxicity. After an acute malignant hyperthermia crisis, patients and their families require counseling about malignant hyperthermia. We also recommend that they join the North American Malignant Hyperthermia Registry, which is a large database that contains information about patients who have had MH or tested positive for MH. This database is used by malignant hyperthermia researchers around the world and is also a resource for family members when wanting to know more information about their malignant hyperthermia episode. We ask that the anesthesia providers that were involved in the malignant hyperthermia episode fill out an AMRA form. AMRA stands for Adverse Metabolic Reaction to Anesthesia. This form can be filled out either anonymously or with the patient's consent with patient data, and the data in this form are entered into the North American Malignant Hyperthermia Registry and again are available for both researchers and patients and their families. Finally, patients should be referred to an MH diagnostic testing center, and I will discuss this in a few minutes when we talk about MH testing. So previously we talked about the signs and symptoms of malignant hyperthermia, but as you know, these signs and symptoms can be caused by other etiologies as well. Some of them occur much more commonly than malignant hyperthermia. These include light anesthesia, dysfunction in the circle breathing system, infection or sepsis, iatrogenic overheating, serotonin syndrome, pheochromocytoma, thyroid storm, or cocaine or ecstasy intoxication. Other etiologies in the differential diagnosis of malignant hyperthermia include other muscle disease, neuroleptic malignant syndrome, myotonic syndrome, cerebral ischemia, ascending tonic-clonic syndrome, rhabdomyolysis, and exertional heat illness. During a typical hotline call, hotline consultants will be asking additional questions of the callers in order to try to ascertain whether one of these other syndromes could be present. Congratulations for making it halfway through the presentation. In the next section, I will discuss the genetics of malignant hyperthermia. Malignant hyperthermia is a genetic disease that is autosomal dominant with variable penetrance. Autosomal dominant means that the malignant hyperthermia patient only requires one abnormal gene in order to manifest symptoms of malignant hyperthermia, and variable penetrance means that the susceptible patient does not necessarily trigger with every exposure to a triggering agent. This pedigree demonstrates the typical inheritance pattern for malignant hyperthermia. In generation 1, one parent has malignant hyperthermia. One of the two offspring in generation 2 has the susceptibility. And in the third generation, 2 of the 4 offspring of the malignant hyperthermia susceptible patient has malignant hyperthermia. In other words, on average, 50% of the offspring of a malignant hyperthermia susceptible patient will inherit the susceptibility to malignant hyperthermia. As you recall from our previous discussion, there is a large protein embedded in the wall of the sarcoplasmic reticulum called the ryanodine receptor, or RYR1, that serves as the calcium release channel of the sarcoplasmic reticulum. The gene for the RYR1 protein is located on chromosome 19. This slide depicts the ryanodine receptor protein embedded in the wall of the sarcoplasmic reticulum. There are at least 4 parts of the protein that are embedded in the wall of the sarcoplasmic reticulum, and then a long tail of the protein hangs out into the space between the sarcoplasmic reticulum and the T tubule. Point mutations in the gene that encode for this protein have been found in a large proportion of malignant hyperthermia susceptible patients. Presumably the mutations in this gene cause abnormalities in the protein that increase the amount of calcium that is released from the sarcoplasmic reticulum into the skeletal muscle cell when the cell is exposed to triggering anesthetic agents. This is an old slide. It lists a number of the early mutations that were identified in the ryanodine receptor. Since this slide was made, a much larger number of mutations in the ryanodine receptor have been identified, and presumably many of these are associated with malignant hyperthermia susceptibility. You recall from our previous discussion that there is a protein embedded in the wall of the T tubule called the dihydropyridine receptor. Several families with malignant hyperthermia susceptibility have been found to have mutations in the gene encoding the dihydropyridine receptor protein. There are other proteins involved in the release of calcium from the sarcoplasmic reticulum, and it is possible that we have not yet identified all of the mutations in all of the proteins that lead to malignant hyperthermia susceptibility. I'd next like to briefly talk about testing for malignant hyperthermia susceptibility. Because of the high likelihood of as yet unidentified gene mutations associated with malignant hyperthermia susceptibility, genetic testing is not the gold standard for diagnosing malignant hyperthermia. Instead, the gold standard test is called the caffeine halothane contracture test. Unfortunately, it's an invasive test that necessitates a muscle biopsy. The muscle biopsy must be fresh, and because the test is only done in a few diagnostic centers across the United States and Canada, the patient must travel to one of these centers in order to have the test done, and this is done at considerable expense. This slide just shows the steps involved in performing a muscle biopsy for the caffeine halothane contracture test. An incision is made in the lateral thigh, and a piece of muscle is dissected from the vastus lateralis and suspended in a tissue bath. The muscle is connected to an electrical source, and tension is generated in the muscle, and then the muscle strip is exposed to halothane, which is one of the volatile anesthetic agents, or caffeine, and the tension generated in the muscle is measured. These two graphs demonstrate the tension that develops in the tissue bath after the muscle is exposed to caffeine or halothane. Along the x-axis is time, and along the y-axis is tension. You can see in the top graph by the solid line that the tension does not change after exposure to caffeine or halothane. And in the bottom graph you can see that the muscle tension increases after exposure to caffeine or halothane, and this is considered an abnormal response. This patient would be diagnosed with malignant hyperthermia susceptibility. Similar to all biological tests, the caffeine halothane contracture test is not perfect. The sensitivity is close to 100%, which means that the false negative test is very low. However, the specificity is closer to 70 or 80%, and this means that there are a significant number of patients who undergo the test who will have a false positive test. They will be told they are malignant hyperthermia susceptible when they really are not. Information about the malignant hyperthermia diagnostic testing centers that perform the caffeine halothane contracture test, as well as information about molecular genetic testing for malignant hyperthermia, can be found on the MHAUS website. Callers who call the hotline asking for this information can be referred to the website. All right, if you need a coffee or tea break, now is a good time. We are about to start on the last section of this presentation. In the last section, we are going to discuss common questions about malignant hyperthermia. Much of this information can be found on the MHAUS website. What anesthetic agents trigger malignant hyperthermia? All of the volatile anesthetic agents trigger malignant hyperthermia. The ones that still might be in use around the world include isoflurane, desflurane, halothane, enflurane, and sevoflurane. And the depolarizing muscle relaxant succinylcholine also triggers malignant hyperthermia. All other anesthetic agents are considered safe. This includes nitrous oxide, which is the only anesthetic gas that is considered safe. Barbiturates, benzodiazepines, propofol, and ketamine do not trigger malignant hyperthermia. Non-depolarizing neuromuscular blocking agents do not trigger malignant hyperthermia, and opioids and local anesthetics are also not triggers. How should the anesthesia provider prepare and care for the patient who presents with a personal or family history of MH susceptibility? First, the anesthesia vaporizers on the anesthesia machine should be shut down and disabled or removed from the machine. The anesthesia machine must be flushed of residual anesthetic vapors. This is a fairly straightforward process for the older anesthesia machines. The oxygen flow can be set at 10 liters per minute, and the reservoir bag can be attached to the Y piece of the circle system, and the machine and ventilator can be cycled for 20 minutes. Unfortunately, it's much harder to flush the newer anesthesia machines of residual vapor, and I'll talk about this in the next slide. The anesthesia provider should make use of this opportunity to check the malignant hyperthermia kit to make sure it is up to date and readily available. Finally, dantrolene pretreatment is not recommended. In other words, the patient should receive a non-triggering anesthetic, but we do not recommend pretreatment with dantrolene in patients who are malignant hyperthermia susceptible. The newer anesthesia machines are much harder to scrub of residual anesthetic vapor because they contain a lot more plastic. Therefore, we recommend that anesthesia providers check with the manufacturer of the machine as to the best method of cleaning their machine of residual anesthetic vapor. Usually these flushes will take greater than 60 minutes. There is additional information about flushing these machines on the MHAUS website. As an alternative, the anesthesia provider might consider placing charcoal filters on both the inspiratory and expiratory limbs of the circle system. These charcoal filters can decrease residual anesthetic concentration to very low levels within a minute or two. Again, it is recommended that the anesthesia provider consult the package insert for these charcoal filters as to their proper use. Often callers will ask if a muscle biopsy needs to be done before surgery in someone who is suspected of being malignant hyperthermia susceptible. The answer is no. As long as a non-triggering anesthetic is performed, a muscle biopsy is not absolutely necessary before a surgical procedure. However, it is recommended that the patient suspected of being malignant hyperthermia susceptible be referred to an MH diagnostic testing center for further evaluation. As noted previously, malignant hyperthermia susceptible patients undergoing anesthesia do not need to be pre-treated with dantrolene. However, they must receive a non-triggering anesthetic. We are often asked how long the malignant hyperthermia susceptible patient should be monitored after an uneventful non-triggering anesthetic. The MHAUS recommends that malignant hyperthermia susceptible patients undergoing an outpatient procedure may be discharged on the day of surgery if the anesthetic has been uneventful. On a minimum period of 1 hour in the recovery room, monitoring vital signs at least every 15 minutes, an additional hour in phase 2 recovery is recommended. This slide summarizes the care of the malignant hyperthermia susceptible patient that we have just discussed. The anesthesia machine needs to be prepared and a non-triggering anesthetic administered. Dantrolene pretreatment is not necessary, but core intraoperative temperature monitoring is recommended. The patient should be monitored in phase 1 recovery for an hour, an additional hour in phase 2 recovery before being discharged home or to a post-surgical unit. We are often asked whether malignant hyperthermia susceptible patients can safely receive local anesthetics for dental procedures. The answer is yes, all MH susceptible patients can safely receive local anesthetics such as lidocaine. Anesthesia providers are often presented with patients who have a family history of malignant hyperthermia. Until proven otherwise, it is usually wise to manage these patients as if they were malignant hyperthermia susceptible, and they should receive a non-triggering anesthetic and be monitored accordingly. We are often asked whether it is safe to use calcium gluconate or calcium chloride for the treatment of hyperkalemia cardiac toxicity during a malignant hyperthermia crisis. This is confusing because part of the pathophysiology of malignant hyperthermia comes from an increase in intracellular calcium levels. The answer is yes. Calcium can be safely used to treat life-threatening hyperkalemic-induced dysrhythmias in patients who have malignant hyperthermia. We are often asked if there are other diseases that are known to be associated with malignant hyperthermia. The only known two diseases that are definitively linked to malignant hyperthermia include central core disease, which is a genetic disease of the ryanodine receptor, and King-Denborough syndrome. There are other diseases that may be associated with adverse anesthetic reactions. These are not malignant hyperthermia. We are often asked about neuromalignant syndrome, which is a disease that presents with symptoms similar to malignant hyperthermia, including fever and muscle rigidity, that is caused by psychotropic drugs. These patients are not at increased risk for malignant hyperthermia susceptibility. Where should a patient suspected of having malignant hyperthermia susceptibility undergo a diagnostic workup? These patients should be referred to one of several malignant hyperthermia diagnostics testing centers. The contact information for these centers can be found on the MHAUS website. The Malignant Hyperthermia Association of the United States recommends that any site that administers a triggering anesthetic be prepared to treat a malignant hyperthermia crisis. Part of this preparation is to have a pre-assembled malignant hyperthermia kit that contains most of the supplies and drugs necessary to rapidly treat a malignant hyperthermia crisis. In fact, many credentialing agencies require the assembly of such a kit. The recommended contents of the kit can be found on the MHAUS website. This slide lists some of the important supplies and drugs that should be in the MH kit or cart. This concludes the presentation on malignant hyperthermia, and I thank you for your attention. In this presentation, we discussed the definition, epidemiology, and cellular mechanism of malignant hyperthermia. We discussed the signs and symptoms of a malignant hyperthermia crisis in the operating room and the treatment, particularly the importance of dantrolene administration. We briefly discussed the genetics of malignant hyperthermia, including mutations in the genes encoding for the ryanodine receptor and the dihydropyridine receptor. We also discussed the caffeine halothane contracture test, which is the gold standard test for the diagnosis of malignant hyperthermia susceptibility. Finally, we discussed common questions that are often posed to the malignant hyperthermia hotline consultants. I'd like to thank you once again for your attention during this presentation, and in particular I'd like to thank you for your willingness to learn about malignant hyperthermia so that you can assist the malignant hyperthermia hotline consultants in advising anesthesia providers and other providers around the country and around the world save lives from malignant hyperthermia. Thank you.